A lot of elbow complaints revolve around the lateral side of the elbow. Classically, this is called tennis elbow. But most people who get this problem don't even play tennis. So we don't really call it tennis elbow anymore. More so we call it lateral epicondylitis, the itis being acute inflammation, or epicondylosis, which is scarring down of that tissue and a change in how the tissue is functioning and working. So with a good evaluation or examination, a good history, we can determine exactly what the problem is. Now, we've already gone through a mapping protocol, so if we also correlate the mapping information with our other evaluation exam findings, we know where to go for that. But just on the complexity of the muscles in the area, so we know, we have our brachioradialis muscle. We have our extensor carpi radialis longus muscle. They cross up and over the lateral epicondyle into the supracondylar ridge of the humerus. Then we have our extensor carpi radialis brevis. That tends to be the most damaged muscle of the common extensor tendon. From there, if you wiggle your fingers, you'll see the extensor digitorum, then we have the extensor digiti minimi, and then we have the extensor carpi ulnaris on that side. So as you can see, there are a lot of muscles in that elbow area. That's why it's good to really identify and break down and figure out exactly what we have. But even when we know exactly with precision where to go, there's generally more than one muscle involved, even if it shows on the MRI, because the common extensor tendon is a combination of those bottom several muscles I mentioned, except for the brachioradialis and the extensor carpi radialis longus. So we're going to put our conducting gel on that area. And we are then going to target our shock waves over the tendon, common extensor tendon, and as we come lower, the specific muscles that we have found on examination or with the diagnostic imaging. Most of the damage will occur in the actual tendon origin portion versus the mid-belly of the muscles or further down. So most of the time the problem is going to be up around the lateral epicondyle, or if it's the brachioradialis or the extensor carpi radialis longus, a little above that area, and then generally 2 to 3 inches below. And we will go up and down the tendon and the muscles, giving more special focus on the ones that are directly involved, but hit them all, and then back and forth. And this is a great approach for patients who have lateral epicondylitis, which is the acute phase injury, or osis, lateral epicondylosis, where it's already scarred up a lot.